Welcome to Working Smarter, Concise Compliance Conversations featuring Wendy Rubis, sponsored by VillageMD, primary care physicians, practice medicine the way you've always wanted, data, resources, and clinical decision support to care for your patients inside and outside the exam room.
Welcome to Working Smarter. This is part 2 of the Medical Malpractice Trends and Best Practices. Dr. Torontow and I recorded this all in one session, but we had a lot to say and a lot to cover, so we broke it into 2 parts. So welcome. Please enjoy part 2 of our conversation. Thank you. MedPro also, as a result of their claim study, they had some case studies, and we're not going to, I'm sure every provider has seen more case studies than they can count. So we're not going to, there's only 2, but they were impactful. And I would say that I wouldn't, if these had happened at Village, I would have, of course, been upset, and we would have done work to, mitigate them and fix processes in place. But is there potential for these to have happened at a Village site? Absolutely. So, these are important, and we have, the case study and then the risk strategies and things that we want you to think about. Dr. Torontow, you probably do a better job of summarizing the clinical case than I would. We'll have this up while hopefully you can read while we're talking through this case for detail, but we'll go over the risks.
Yeah, let's go through the bullets. I mean, again, briefly. So we have a 64-year-old female patient who has COPD and is a smoker, has hyperlipidemia. We have, quote, acid reflux, aortic valve issues, depression, and documented non-compliance, which is always an interesting documentation to put in the chart. Was seen by the PA as a walk-in, needed refills. It sounds like there was no complaints of GI pain or nausea. The meds were refilled by the physician assistant. The labs were ordered and reviewed. The hemoglobin was 7.4, and not hemoglobin A1C, but hemoglobin 7.4, and that the patient should be seen in the office. Then there was unknown, whether there's no documentation, the PA notifying the patient of the abnormal lab. So again, this is one of those things where it sounds like that it was written down, but then no one actually, like, someone should follow up and bring this person back in, but then there was no actually external communication to bringing them back in. The patient actually called and wanted a refill of her medications. And there was no ongoing documentation or evaluation of the patient's response to medication. So again, we all get busy, the patient calls and needs refills, we do refills. The PA had authorized Tylenol 3 Xanax. So call out, just get on my soapbox really quickly. Opiates and benzos should never be a thing. And this is actually, then there's clonazepam on this list, and oxybutynin, so muscle relaxer. So this is this particular cocktail is not great. The patient was admitted 3 weeks later for a massive GI bleed and found to have a large ulcer with clotting. She deteriorated. If anyone has ever managed anyone with an upper GI bleed, those folks don't usually do very well. And then this patient died. Family claimed that the physician assistant failed to investigate the low hemoglobin, failed to refer to GI for ongoing complaints of abdominal pain, and acid reflux that resulted in a GI bleed. Experts could not support the PA in light of lack of supervision. No supervision or medical physician review was noted on the medical record. So there's a lot of interesting things here to unpack in this particular case.
So there's a lot to unpack from that case, and it's rich. And you can see, when I talked about the difference between failure to diagnose and failure to treat, we ordered the right test. We ordered the hemoglobin. Now we got an abnormal result. We did not act. When I say we,
we'll own it. Yeah, we'll totally own it.
Yeah. So we failed to act upon it. So again, these are the risks for primary care. So the 360 lab and test tracking, we have to do a good job on that. We have to do a timely review of results when they come in. a hemoglobin and abnormal, not a critical, we can't have that sitting for days and days. So we have expectations and best practice on when things need to get reviewed. And so that's a big part of it. Again, patient medical non-adherence will not excuse the failure of the provider to follow up. So, again, this is where documentation becomes your best friend. This is where boundary setting, crucial conversations are important. I really do need to see you. I can't refill your medications again until you come in. Those crucial conversations, and explaining why, and that, it's in their best interest, it's in your best interest, that, this is a relationship that we need to be, positive, and to manage your care in the best way possible. We need to, lay hands on you. We need to actually perform an assessment and do labs and, all of the things that we do to manage patients. And again, the assessment on the ongoing basis on drugs. So the analysis of the medications that we're providing, again, can't be understated. Getting curious, asking, well, how long have they been on this medication? Why were they originally placed on it? And is it at the point where we need to assess, how's it going? Is the plan to stay on it? Is the plan to get off of it? When is it? And having that conversation with the patient as well. So important. And then, I know that we're building a really good process around that supervision of APPs at Village. But again, encourage all APPs, to reach out as well. You have a supervising provider for advice and for that reason, because they're supervisory. So you have, resources and options to assist you and to help you. So, all of these call outs are so important.
No, no, I think you're spot on. I think often, and I shared with the group, I think I shared it in another setting, that the use of language in the electronic health record that sort of shows bias, and this concept of using something as simply as, saying non-adherent, writes the patient off in a way that sort of that makes it hard for you to take care of that patient with a clear mind, because what you've done or someone else has done is sort of blame the patient for their own condition. And, I could look through this chart and say, oh, there are a lot of things going on with this patient. This patient's doing, quote unquote, to themselves. That doesn't excuse us of our responsibility of actually helping them take care of themselves, right? It is a two-way street, and we need to meet that patient where they are. It's not all on the clinician to fix things, but it is on the clinician to bring the patient into that space where they can fix things themselves. And when you use things like non-compliant, that can be a problem. So I would just encourage people not to use those words, because it biases you and your colleagues.
Yeah. All right. Case study number 2. I will let Dr. T walk through the clinical piece of this as well.
All right. So in our second case here, we've got a treatment failure to follow up. A 74-year-old patient with hypertension and CAD, who'd been treated, had chronic sinusitis and treated with multiple antibiotics. There was a documented and a note from a specialist of a ampicillin allergy or a penicillin. So that would include, all penicillins and cephalosporins. Later, the patient came in, and the allergies that were updated, it looks like in the medical record, did not include the penicillin allergy, but it was in the medical record. Again, when the patient came in with another infection, the nurse practitioner failed to really do a chart review, asked the patient about the allergy. The patient didn't recall the allergy. Short story, the patient was given Keflex, allergic to a known allergy to penicillin, which would be contraindicated. The patient had an anaphylactic reaction and died. And the nurse practitioner said, well, if she'd been aware, she wouldn't have ordered Keflex. The spouse contended that both the PCP and the nurse practitioner didn't discuss the patient's history of allergies. Neither provider documented discussion of allergies. PCP alleged that the patient minimized his allergic reaction to skin reactions, Penicillin allergy was also documented in the pharmacy records, but the pharmacy contends the information was added after the patient's death. So again, there's a little bit of confusion here, and I think there's some things here that are worth paying attention to. But let's go into the summary, and we'll come back.
Yeah, it's all ties into the history of records. Patients are poor historians. We know this. Um, they might lack, total medical knowledge. I mean, I know my dad, for example, he is a smart, educated engineer, but if you ask him anything about his medical history, he does not know the answer. So, making sure that especially in cases like that where they could be a poor historian, really scrubbing historical records and the information that is or could be buried in the history is so important to make sure. And I know it's time intensive and I know it's difficult, but the burden, one of the responsibilities is to make sure that we've done a thorough review with the information that we have and that we've been given. So that's kind of a key piece.
Yeah, no, I think that's super important. In terms of allergies, if you were to look at the data and say the number of patients who say they're allergic to, a penicillin, that's probably only half or less than half are actually truly allergic. That being said, if it's in the chart, it's worth avoiding. Unless you're going to go to the trouble of actually desensitizing the patient or sending them to an allergist if you've got to treat them with an ampicillin, or if there's some reason that you have to use a penicillin based antibiotic. But you can't use that if it's in the chart as an allergy. It's an allergy. In this case, it's not. The somewhere buried in the chart was the penicillin allergy. It looks like. It's really important. We've all learned to always ask, do you have any allergies? And if someone says they have an allergy, then that's an allergy until proven otherwise. But this is really an example of folks really not paying attention, to your point, and making sure that, again, when you have that annual wellness visit, take the time, perfect time to buff the chart, make sure that everything's up to date. That is another advantage of that annual wellness visit, hint, hint. But yeah, again, this is probably more, this scenario that was just described is actually more common than folks would realize.
Mm-hmm. All right, we're wrapping up. We're getting near the end here. So lessons learned, best practices. This is over 37,000 claims and suits. They're showing which were the key contributing factors. So failure to have or follow a policy or protocol. I encourage all the providers. There is a clinical policy and procedure committee. Dr. Toronto and I are both on it. We are building clinical best practices for you. I encourage you to make sure that you know where those are located, that you've seen them, that you understand how to use poly. All of our clinical guidelines and guidance are there to serve and help you. So just wanted to call out that, and also if you think that we don't have a policy or a protocol that we need, we have a list of things that we're working on and strengthening and adding at Village. And all of this is to help you practice better medicine and to have the resources that you need versus if you are practicing alone. So all of the work that we do at the Clinical Policy and Procedure Committee, all of that is to build, protocols and policies for you to practice better. So just wanted to call that out and make sure that, you know about them, you've seen them, you know how to access them, and if you have ideas to bring them forward.
No, I think that's a great call out.
And then in terms of, again, I would say most primary care providers know this. So we're not telling you things you didn't know, but just it's worth the time just to have a call out, have a moment to think about this, that, an appropriate and thorough assessment, of course, is, one of the most important things that you do as a provider. The communication, which we've tied on, is so huge. Communicating with other members of the care team is so huge. Engaging with patients and then documenting all of the work that you did. you deserve credit for all of the things that you are doing. So the documentation on that is huge. And again, the review of office processes, if you have suggestions, if you have, I would encourage, contact me, fill out an incident report. Any thoughts you have, please bring them forward, because we want to mitigate this risk for all of you so that you can practice medicine to the best. We're providing you the best, environment to practice the best medicine you can.
No, I think those are super important. And some of this is sort of the new world order in terms of, truly patient-centered care. The communication part cannot be undersold, really understand, trying to bring your patients, engage them in their own care, assessing them for their ability to understand what you're talking about and really walk through shared decision-making is super important. And is, if it's not now, it will be tomorrow, the standard of care in medicine. Documentation, I would encourage folks to really, if you're not up to date on the new guidelines of 2021 guidelines, to look at those and look at those again, because the notes that I look at even today are really still heavily weighted with lots and lots of review of systems and other things that aren't necessarily, they're important. Don't get me wrong, they're important to that, for that assessment. But what we don't see enough is the actual spelling out of the medical decision making in the assessment and plan, which is actually the way the new guidelines are set up. That's actually where all the emphasis is. So I would encourage people to really make sure they're actually really spelling out their thinking, just putting their thinking into that assessment and plan every time they see a patient.
Agree. So the rest of this is just, how do you contact risk? If you have a concern, you think you have a potential claim, this is just, my little spiel of, please reach out. If you're worried about a case, if you're worried about something in terms of the med mal world, a process, anything, please just reach out, and feel free to contact. And with that, just thank you so much, Dr. Toronto, for having this conversation with me and letting us share this important information with our providers.
Well, thank you, Kelley. It was great talking to you. It's always great working with you. I always learn something from you every time I do. And folks, always reach out to Risk. The risk management team is on your side all the time. Even when they probably shouldn't be, they'll still be on your side, because that's their job. So don't hesitate to reach out to Risk if you have any questions.
Perfect. Thank you, Dr. Toronto, and thank you all for listening.
Thank you. Thanks for having me.
Thank you to our sponsor, VillageMD. We hope you will join us for future concise compliance conversations.